And when all this breaks down, when things go terribly, terribly wrong with the immune system, when it stops being able to differentiate self from not self, when it over-exaggerates its response, when it gets confused, or when it stops differentiating, then we start getting into a variety of named diseases. We'll call it asthma, we'll call it allergies, we'll call it inflammation, we'll call it autoimmunity, we'll call it cancer, we'll call it rashes. We're going to put some names on it. And maybe you've not seen all of those names on one slide in one place, because in medicine, we kind of chop all this stuff up. Now, do you know why we chop it all up? So that we can assign a specialist to each and every one of these areas. And when we do that, we create a very, very narrow focus. So there are people that highly specialize in inflammation, and those that specialize in autoimmunity and rashes and asthma and allergy. And there are some individuals that try to do their best in primary care to triage all of this, decide what they can help and what needs to go to a specialist. But this is very much a thought process in medicine, is what is it in front of me and who does it belong to? Now, I would contend that that is a type of thinking which is called label thinking. I don't like it. It doesn't help me as a physician at all. I haven't practiced label thinking ever in the way that I've thought about things. But let me teach you about how label thinking works. Label thinking works is that you take some signs and symptoms. A patient comes in and they say, I have this particular complaint. I have this particular issue, and on exam you find a particular set of findings. And you run some labs and some imaging studies, and you're certain that you have enough data in about that patient. You're using the data to ascribe a label to it. The label has a fancy name in medicine because we can't charge as much if we call it a label, so we're going to call it a diagnosis, okay? The diagnosis is a label. It's a name of something that's there. Now, we do this for one reason, and one reason only, which is to eventually come up with a particular treatment. So we're going to use a pill, potion, powder, or lotion, which is coming off of something called a formulary. It's a list. If you have this label, you look at where the label is on this list, and you have the best thing to do, the second best thing, and the third best thing to do. And although it sounds very formulaic, very rote, there is very much what's called a standard of care, which ascribes for every single set of signs and symptoms, there's a label, and for every label, there's something that you do, and there's one more thing to tack onto it, which is you put an ICD code on it, which helps you to get paid. That completes the entire medical paradigm of label thinking. And if you happen to be caught in this and not getting better, it really stinks. Because you get the label, but you don't sometimes feel any better. And you feel a little caught because the label goes to a certain type of practitioner, and if that practitioner can't help you in the purview that they're looking at, you're kind of a bit stuck. You've gone to the very bottom of the granularity of medicine without getting anything for it. I don't like this thinking. I've taught it, but I don't like it. I like to think differently because nobody likes to be a label. You ever see somebody just celebrate their labelness? Some people do. Like if you're going to the doctor for the first time with a set of symptoms and you say that I have a red area here that is particularly irritating and nasty, and sometimes when certain clothes that I wear are placed on it, it gets even worse. And a physician says to you, well, you have contact dermatitis. And you go, thank goodness. Someone has finally told me what I have, because now I have a treatment. Now, do you know what they told you? They told you that something was contacting your skin and making it red, irritated, and inflamed. Derma is skin, itis is inflammation, contact is contact. But we felt better with the diagnosis. Now, the diagnosis would lead to what? A treatment, which would lead to an ICD code, and everybody seems to be happy as long as the treatment solves things. If it doesn't, you're going to need a different way to approach it. Tonight is just another paradigm of how to look at this. I'm not saying it's right or wrong. I'm saying it's me and a bunch of other people that think like me, but it's not right or wrong. It's a different paradigm. And it's what's called a functional paradigm. And functional thinking is different, totally different. We don't really even care that much about the labels, because the labels are pretty much as silly as they sound. What we think about is what is imbalanced in the body. What you be a sleuth. You have to turn on a different part of the brain of thinking, a different line of questioning. What is imbalanced in the body that is causing the contact dermatitis, the redness, the irritation? Why is it responding when it didn't respond before? And it's about understanding and not necessarily naming. The naming isn't very gratifying in functional medicine because the name doesn't lead us any closer to the end goal. I'm going to teach you the end goal in a second, but it really deals with dysfunction, the lack of function in the body, and not a naming of a disease. Now, to do this, to get here, we have to start with somewhere. And when I'm working with a patient, the first thing I think about is like, what's the gene pool? We have 20,000 generations of genes sitting in front of me at the moment. Some of them are turning on and some of them are turning off, and we know a lot about a few of them right now. We're about almost 20 years, 18 years into the genomic revolution. We're doing okay. We're learning more every single day about this, and I'm humbled by what I learn and how I can place it into practice with patients. But I do sit there and I think about what are the unique genetic areas? What am I hearing about in the family history that's telling me that this individual has a different name, but is still very much a very similar autoimmune expression? When we start getting a little more granular in discussion with patients, I'm really digging in, asking probably 100 different questions about all the different past influences in their life. What led up to this point? What has occurred for them? Multiple rounds of antibiotics, operations, the use of steroid medication, pregnancies, all these terrible infections. What has had the influence on the immune system up until this point? And then what has triggered it? Why are they in front of me today? What was the tipping point? Because there's usually a tipping point. Symptoms can be non-existent, or symptoms can be very low level, but there's always a tipping point where they suddenly at one point become very exaggerated for many people. It's interesting to me and important. Then I think about mediators. What is it that makes it better? And there sometimes are things that make it better. They tell me a lot because they're telling me how this person, the patient in front of me, is influencing their function. They're changing their habit in their life and creating an endpoint that's making it better. But ultimately, it gets me to the root cause. That's the golden ring. That's what I think about every single moment of every single day with every patient. What is the root cause? What is it that took them from where they were to where they are today? What was the underlying foundational shift that occurred that led to them having this expression of a whole bunch of signs and symptoms? That really helps me, because this doesn't help me so much. When I think about this, it makes me frustrated because it's very hard to get traction with this. But if you think about this a little bit differently and you say, okay, I wonder if all of these things really aren't the end result, but really, essentially, the last domino to occur from an underlying root cause.